1 in 3 Americans is walking around with high blood pressure right now, and the vast majority of them are doing exactly what their doctor told them, cutting back on salt, maybe dropping a few pounds, dutifully refilling their prescription every 3 months, and yet the numbers won't move. I've watched this cycle repeat itself hundreds of times in clinical practice. Same readings, same conversation, same prescription, slightly adjusted. And what genuinely troubles me, isn't that doctors don't care. It's that a 12-minute appointment is structurally incapable of teaching anyone the actual biology of what's driving their blood pressure up. Nobody explains the mechanisms. Nobody connects the dots. Patients leave with a pill and a pamphlet about sodium, and that's considered sufficient. It isn't. I'm Dr. Alex Thompson. I've spent over 2 decades in medicine, and today I'm going to show you the 10 mistakes that keep blood pressure stubbornly elevated in people over 60, what's actually happening inside your arteries when you make them, and what the evidence says you should do differently. Some of what I'm about to tell you will contradict what you've been told your entire adult life. First, understand what's actually at stake here. Hypertension is uniquely dangerous precisely because it feels like nothing. You can carry a systolic pressure of 175 for years going about your life, feeling perfectly fine right up until the morning you can't. That morning might look like a crushing chest pressure that radiates down your left arm. It might look like waking up unable to form a sentence. It might look like a hemorrhage in the brain from vessels that have been absorbing excess mechanical force every single heartbeat for a decade. What's happening beneath the surface is silent and relentless. Your heart thickens from the effort of pumping against elevated resistance. Your kidney filtration gradually deteriorates. Your arterial walls stiffen and narrow. The downstream consequences, heart attack, stroke, kidney failure, heart failure, don't appear without warning. They appear after years of warning that registered as no symptoms whatsoever. A prescription manages the number. It does not address what created it. That distinction is everything, and it's exactly what we're going to unpack today. Mistake number 1. Believing your blood pressure is mostly a salt problem. Let me be direct with you about something the medical establishment has gotten significantly wrong, not maliciously, but consequentially. For decades, hypertension has been reduced to a single villain: sodium. Cut the salt shaker. Read the labels. Watch your sodium. And if your numbers stay high anyway, cut it further. This narrative is so deeply embedded in American medicine that questioning it almost feels irresponsible. But here's what the science actually shows. Sodium matters, particularly in people who are salt sensitive, a real and clinically significant subgroup, disproportionately represented in adults over 60. I'm not dismissing that, but telling someone that hypertension is primarily a salt problem is like telling them a house fire is primarily an oxygen problem. Technically accurate, completely misleading, because you're identifying a background condition while ignoring the match that struck it. In modern Americans, especially those over 60 who have spent decades eating the standard Western diet, the most significant and under-addressed driver of elevated blood pressure is insulin resistance. Here's what that means in practical terms. When your insulin levels remain chronically elevated, which happens gradually, almost invisibly, after years of refined carbohydrates and processed food, 3 things begin occurring simultaneously inside your body. Your kidneys shift into sodium retention mode, holding onto water and expanding your total blood volume. Your sympathetic nervous system, the same system designed to prepare you for emergencies, becomes stuck in a state of low-grade chronic activation, and your arterial walls progressively lose their capacity to relax and dilate between heartbeats. 3 separate mechanisms, all operating in parallel, all pushing your pressure upward every hour of every day. This is why the cluster of conditions so familiar to Americans over 60, abdominal weight gain, prediabetes, fatty liver, metabolic syndrome, doesn't just accompany hypertension, it generates it. These aren't coincidences sharing a zip code. They are expressions of the same underlying biological dysfunction. Restricting sodium without correcting the metabolic environment is like mopping the floor without turning off the faucet. You're managing a symptom while the cause continues operating undisturbed beneath the surface. That's not treatment. That's maintenance of the problem. Mistake number 2. Eating ultra-processed food without realizing what it's actually doing to your blood pressure. This follows directly from everything I just explained, and for most Americans over 60, it may be the single most impactful change available to them. Let me define what I mean precisely, because processed food has become such a broad term that it's lost its clinical usefulness. I'm not talking about frozen vegetables or canned beans. I'm talking about products engineered in laboratories to be chemically stable, artificially palatable, and infinitely shelf-stable. Foods with ingredient lists that read like industrial supply, manifest emulsifiers, modified starches, synthetic preservatives, flavor compounds with names that require a chemistry degree to pronounce. If you handed it to someone from 1950, they wouldn't recognize it as food. Because by any historical standard, it isn't. Here's what these products do inside your body, and I want you to understand this at a biological level, not just as dietary advice. Ultra-processed foods are architecturally designed to bypass your body's satiety signaling. They are calorie-dense and fiber-depleted, which means they drive insulin secretion rapidly and repeatedly, without ever producing the hormonal signal that tells your brain you've had enough. Eaten consistently over years, which describes most Americans' relationship with these products, this pattern progressively degrades your cell's sensitivity to insulin. And as we established in the last section, chronically elevated insulin is one of the most powerful drivers of sustained hypertension. That's the first mechanism. The second is more straightforward, and arguably more shocking. The sodium hiding inside ultra-processed food dwarfs anything coming from your salt shaker. A single serving of canned soup, a fast food breakfast sandwich, 2 slices of deli turkey on commercial bread, these routine, unremarkable choices can collectively deliver 3 to 4 times your recommended daily sodium before dinner. Most people over 60 who believe they're watching their salt intake are dramatically underestimating their actual consumption because they're focused on the shaker and ignoring the package. When you systematically reduce ultra-processed food, you are not making one dietary change. You are simultaneously withdrawing the primary driver of insulin resistance, eliminating hidden sodium at scale, reducing visceral fat accumulation, and restoring your body's ability to regulate its own pressure. Few interventions work on that many mechanisms at once. This one does. Mistake number 3. Underestimating what the fat around your organs is actually doing. Most people over 60 have made a reasonable peace with carrying a little extra weight. It feels inevitable, expected, a natural consequence of decades of living. And if it doesn't hurt and the doctor hasn't raised serious alarm, it's easy to file it under something to work on eventually. But there is a specific type of body fat that demands your immediate attention, not eventually, but now. Visceral fat is not the fat you can pinch at your waistline. It's the fat packed deep inside your abdominal cavity, wrapped around your liver, your pancreas, your kidneys, your intestines. And unlike subcutaneous fat, which is largely passive storage, visceral fat is biologically active in ways that are genuinely alarming once you understand the mechanism. Think of it less as stored energy and more as a rogue endocrine organ that has taken up residence in the center of your body, one that is continuously secreting inflammatory molecules into your bloodstream, actively degrading your cell's sensitivity to insulin, and directly stimulating 2 of your body's most powerful pressure-elevating systems, the sympathetic nervous system and the renin-angiotensin system, which is the master hormonal regulator of blood pressure in your kidneys. Every hour of every day, visceral fat is sending biochemical signals that instruct your cardiovascular system to operate at higher pressure. It doesn't pause when you sleep. It doesn't take weekends off. A practical way to assess your own risk: divide your waist circumference by your height, measured in the same units. If that number exceeds 0.5, your visceral fat burden is clinically significant and almost certainly contributing to your blood pressure. Here is the genuinely encouraging part. Visceral fat responds to lifestyle intervention faster and more dramatically than any other fat depot in the body. And the clinical data on weight reduction and blood pressure is remarkably consistent. For every kilogram of weight lost in overweight individuals, systolic blood pressure falls by approximately 1.1 millimeters of mercury on average. Losing 20 pounds translates to roughly a 10-point reduction in systolic pressure. For many patients over 60, that single change has been sufficient to eliminate the need for medication entirely under physician supervision. That is not a minor outcome. That is transformation. Mistake number 4. Measuring your blood pressure incorrectly and making medical decisions based on numbers that aren't real. This one tends to surprise people. It sounds administrative, technical, like a footnote compared to the bigger conversations about diet and metabolism. But I want you to understand why this mistake may be the most immediately consequential one on this entire list. If you are managing your blood pressure based on inaccurate readings, adjusting medications, assessing your progress, deciding whether lifestyle changes are working, you are not managing your blood pressure at all. You are managing a number that doesn't accurately reflect your biology, and the downstream consequences of that are serious. Here is what most people don't appreciate. Errors in measurement technique don't produce minor distortions. They produce shifts of 5 to 15 millimeters of mercury in either direction. To put that in clinical terms, a 10-point error in your systolic reading is the difference between your physician adding a second medication to your regimen and your physician telling you your pressure is well controlled. Same patient, same arteries, completely different medical trajectory, determined entirely by whether the measurement was taken correctly. So let's go through exactly where people go wrong. The cuff size matters more than almost anything else. A cuff that is too small for your arm will overestimate your blood pressure consistently and significantly. If you are purchasing a home monitor, bring your arm measurements. This is not optional. Your arm position matters. The cuff must be positioned at heart level. An arm resting in your lap during measurement can add 5 to 6 points to your reading. Your feet must be flat on the floor. Crossed legs elevate pressure measurably, and almost everyone crosses their legs by habit without realizing it. Conversation during measurement is extraordinarily common and extraordinarily disruptive. Even casual talking, answering a question, commenting on the weather produces immediate and significant pressure spikes. Sit silently. Without exception, timing matters more than most patients are ever told. Measuring within 30 minutes of caffeine, physical exertion, emotional stress, or even a brisk walk from the parking lot will give you a reading that reflects those stimuli, not your true resting cardiovascular state. The most underappreciated requirement of all. 5 full minutes of quiet seated rest before every measurement. Not 2 minutes. Not standing in the hallway waiting for the nurse. 5 minutes of genuine stillness. For home monitoring, which I strongly recommend for everyone over 60, because white coat hypertension is both real and clinically significant, take 2 to 3 readings spaced 1 minute apart. Record the average, and repeat this 2 to 3 times daily during monitoring periods. A single rushed measurement taken under imperfect conditions tells you almost nothing reliable. A properly executed series of readings tells you everything you need to know. The data is only as good as the method that produced it. Mistake number 5. Not eating the foods that tell your arteries to open. This is the one I find most clinically underappreciated and the one that produces the most visible reaction when I explain the mechanism to patients who have been managing hypertension for years. Because what I'm about to describe is a physiological pathway that is extraordinarily well established in the research, produces effects comparable to pharmaceutical intervention, costs essentially nothing to implement, and is almost never mentioned in a standard medical appointment. Certain foods, beets, spinach, arugula, celery, Swiss chard, dark leafy greens broadly are naturally concentrated in inorganic nitrates, and when you consume them, a remarkable biological sequence is set into motion. The bacteria that live naturally in your mouth begin converting those dietary nitrates into nitrites. Those nitrites travel into your bloodstream, where your body converts them into nitric oxide, one of the most potent vasodilators in human physiology. Nitric oxide transmits a direct chemical signal to the smooth muscle tissue lining your arterial walls, instructing them to relax and expand. When your arteries widen, the pressure inside them drops. Immediately. Measurably. This is not alternative medicine. This is established vascular biochemistry, confirmed across multiple randomized controlled trials with rigorous methodology. Studies examining dietary nitrate consumption, particularly from beets, have demonstrated reductions in systolic blood pressure of 4 to 10 millimeters of mercury. I want you to sit with that number for a moment, because that is not a modest dietary effect. That is the magnitude of reduction produced by certain first-line antihypertensive medications, achieved by eating vegetables. Most Americans over 60 consuming a standard Western diet are obtaining virtually no dietary nitrates. Ultra-processed food, which, as we've established, dominates the modern American plate, contains essentially none. The arterial relaxation pathway that these nutrients activate is simply lying dormant, never triggered, in the majority of people whose blood pressure we're trying to manage. Now here is the detail that stops people cold when I share it. If you use an antibacterial mouthwash twice daily, which millions of Americans do, completely reasonably, for dental hygiene, you are eliminating the oral bacteria responsible for that critical first conversion step. The nitrates enter your mouth, and the bacteria that should transform them into nitrites are gone. The cascade never begins. The arterial signal never fires. You could be eating beets every single day, and blunting the cardiovascular benefit entirely without ever knowing it. The protocol here is straightforward. Eat beets regularly. Build spinach, arugula, and dark leafy greens into your daily meals consistently. Skip the nitrate supplements and bottled juices. Whole food form is what the research supports. And reconsider twice daily antibacterial mouthwash if blood pressure management is a priority. One simple shift in what grows on your plate. One profound shift in what happens inside your arteries. Mistake number 6. Ignoring the mineral that acts as your body's natural blood pressure regulator. We've spent considerable time on sodium. Now I want to tell you about the mineral on the other side of that equation, the one that almost nobody discusses, that most Americans over 60 are chronically deficient in, and that may be doing more damage to your blood pressure through its absence than sodium is doing through its excess. That mineral is potassium. Inside your body, potassium and sodium exist in a perpetual biological negotiation. They are physiological opposites, operating in careful dynamic balance. Potassium instructs your kidneys to release sodium rather than retain it, directly countering one of the primary mechanisms by which blood pressure becomes elevated. Simultaneously, potassium signals the smooth muscle tissue in your arterial walls to relax, the same fundamental outcome produced by the nitric oxide pathway we discussed in the previous section, achieved through an entirely different mechanism. When potassium is abundant and sodium is moderate, this system functions with remarkable precision. Your kidneys regulate fluid volume efficiently. Your arteries maintain healthy flexibility. Your pressure stays controlled. When potassium is depleted and sodium is elevated, which is the precise biochemical profile produced by a standard American diet built around ultra-processed food, the system collapses in the direction of sustained hypertension. Your kidneys hold sodium. Your arteries constrict. Your pressure climbs and stays there. Here is what makes this particularly striking. The research on potassium and cardiovascular outcomes is not preliminary or contested. Large-scale population studies consistently demonstrate that higher dietary potassium intake is independently associated with lower blood pressure across diverse populations. More significantly, for anyone over 60, elevated potassium consumption is associated with meaningfully reduced stroke risk, one of the most devastating consequences of sustained hypertension, and one of the leading causes of disability and death in Americans in this age group. This is not a minor correlation. It is a robust, replicated finding across decades of epidemiological research. And the foods that deliver therapeutic levels of potassium are not exotic, expensive, or difficult to incorporate. Baked potatoes, one of the most potassium-dense foods available. White beans, lentils, black beans, wild-caught salmon, dark leafy greens, avocados, and yes, bananas, though far from the only or most potent source. These are foundational whole foods that belong at the center of any intelligent dietary approach for adults over 60. The profound irony of the modern American diet is this. We have engineered an eating pattern that simultaneously floods the body with sodium, while stripping away the one mineral specifically designed by human physiology to counteract it. Restoring that balance doesn't require a prescription. It requires understanding what your body was designed to run on and returning to it deliberately, consistently, and without apology. Mistake number 7. Treating physical stillness as a neutral choice. There is a quiet assumption embedded in how most Americans over 60 think about their daily activity, that resting is simply the absence of doing something. A neutral baseline that neither helps nor harms. You're not exercising, but you're not doing anything wrong either. You're just sitting. That assumption is physiologically incorrect. And for someone managing elevated blood pressure, it is one of the most expensive misconceptions they can hold. Prolonged physical inactivity is not a neutral state for your cardiovascular system. It is an active contributor to the biological conditions that sustain hypertension. Every system we have discussed in this series, insulin resistance, visceral fat accumulation, arterial stiffness, sympathetic nervous system overactivation, is directly worsened by chronic sedentary behavior. Sitting doesn't simply fail to help. It accelerates the damage. Now here is the evidence, stated plainly. Meta-analyses examining the relationship between regular aerobic exercise and blood pressure in hypertensive individuals are among the most consistent bodies of data in all of cardiovascular medicine. The findings replicate across populations, age groups, and study designs. Regular sustained aerobic movement reduces systolic blood pressure by 7 to 12 millimeters of mercury in people with hypertension. I want to be precise about what that means clinically. A 10-point reduction in systolic pressure is not a modest lifestyle benefit. It is the magnitude of effect produced by certain first-line antihypertensive medications, achieved without a prescription, without side effects, without cost, through movement alone. The mechanisms behind this are multiple and interconnected. Regular aerobic exercise progressively improves your cell's sensitivity to insulin, directly addressing the metabolic dysfunction we identified as the root driver of modern hypertension. It mobilizes and reduces visceral fat, the biologically active abdominal fat that continuously signals your cardiovascular system toward higher pressure. It improves the structural elasticity of your arterial walls, which stiffen naturally with age and become increasingly resistant to relaxation. And over weeks of consistent practice, it measurably reduces the chronic activation of your sympathetic nervous system, essentially lowering the background stress signal your cardiovascular system operates under around the clock. Here is what I want every person over 60 to hear clearly. None of this requires intensity. The evidence does not point toward vigorous exercise as the threshold for cardiovascular benefit. It points toward 150 minutes per week of moderate aerobic movement activity that elevates your heart rate and breathing without exhausting you. That translates to 30 minutes 5 days a week. Or, more practically, and perhaps more powerfully, 10 minutes of walking after each of your 3 daily meals. Post-meal walking specifically blunts the blood sugar spike that follows eating, directly reducing the insulin demand that drives metabolic dysfunction. It is gentle. It is sustainable. It is accessible to virtually every ambulatory adult, regardless of fitness level, and sustained consistently over 6 to 8 weeks. It produces changes in your blood pressure that are real, measurable, and clinically meaningful. Movement is not optional maintenance. For your arteries, it is essential medicine. Mistake number 8. Not understanding what your blood pressure is doing while you sleep. Most people think about blood pressure management as a daytime problem. You monitor your readings in the morning. You take your medication with breakfast. You make choices throughout the day about what you eat and how much you move. And then you go to sleep. And you assume the problem pauses with you. It doesn't. What happens to your cardiovascular system during the hours you're unconscious may be just as consequential as anything occurring during your waking hours. And for a significant proportion of Americans over 60, the nighttime is precisely where the most damaging pattern is unfolding, completely invisibly, completely silently, completely unaddressed. Here is what healthy sleep does for your blood pressure. In a normal restorative sleep cycle, blood pressure naturally decreases by 10 to 20% overnight. Physicians call this nocturnal dipping. This nightly pressure reduction is not incidental. It is physiologically purposeful, a critical window during which your vascular system recovers. Arterial walls undergo cellular repair, and the accumulated mechanical stress of the day's cardiovascular demand is partially reversed. Your arteries are, in a very real biological sense, healing themselves while you sleep. When sleep is chronically insufficient, fragmented, or poor in quality, which describes the sleep reality of a substantial majority of Americans over 60, that nocturnal dip is blunted or eliminated entirely. Your cortisol levels remain elevated through the night. Your sympathetic nervous system, which should be quieting during sleep, stays partially activated. Your arterial walls maintain elevated tone rather than relaxing into the recovery state they depend on. You wake up the next morning with a cardiovascular system that has been running under pressure for 24 consecutive hours without relief. Do that for months. Do that for years. Then wonder why the medication isn't working as well as it should. Which brings me to the most underdiagnosed cardiovascular condition I encounter in patients over 60 with treatment-resistant hypertension: obstructive sleep apnea. Sleep apnea occurs when the airway repeatedly collapses during sleep, causing breathing to stop sometimes dozens or hundreds of times per night, triggering a cascade of oxygen deprivation, cortisol surges, and sympathetic nervous system activation with every single episode. The pressure consequences are severe and cumulative. When a patient's blood pressure is failing to respond adequately to multiple medications, sleep apnea is among the first conditions I investigate. The warning signs are specific: loud, persistent snoring, waking with headaches or feeling completely unrefreshed regardless of hours slept, excessive daytime fatigue that seems disproportionate to your activity level, a partner reporting that you stop breathing, gasp, or startle repeatedly during the night. If any of those descriptions feel familiar, if you recognized yourself in even one of them, please raise this with your physician immediately. A sleep study is straightforward. The intervention, if apnea is confirmed, can produce blood pressure reductions that medication alone has failed to achieve. Your arteries need you to sleep well. That is not metaphor, that is medicine. Mistake number 9. Underestimating what alcohol is doing to your arterial pressure every single day. I want to approach this one carefully, because it sits at the intersection of physiology and identity in a way that most of the other mistakes on this list do not. For many Americans over 60, drinking is woven into the fabric of social life. Dinner with friends, a glass of wine with a spouse after a long day, a celebratory toast at a family gathering. These are not trivial things. They carry meaning that exists entirely outside the domain of medicine. I understand that, and I want to honor it while being completely honest with you about what the science shows. Alcohol has a dose-dependent relationship with blood pressure that is among the most consistently documented findings in cardiovascular research. That phrase, dose-dependent, means precisely what it sounds like. The more regularly you drink, and the more you consume, the higher your baseline arterial pressure tends to be. This is not a correlation that disappears when researchers control for other variables. It holds across populations, age groups, and drinking patterns.